Good afternoon. This is Dr. Craig Stern from Pharma Pharmaceutical Consultants and ProData Analytics. We are doing our weekly Wednesday news brief. This is a follow-up really to the RxInfoX exchange that ProData puts on and has updates in news on a daily basis. Today I want to kind of, if you will, read some of the news to you that's important and try and bring up some things that are going on, both from a standpoint of things that are important, but also issues that have to deal with perhaps problems with some studies. So if you don't mind, I am going to refer to some of the studies just to bring some of these issues up. The first one has to deal with opiates. Obviously, opiates are a huge issue and everyone is talking about it. The main issue that people are talking about are patients that are getting opiate medications who necessarily you wouldn't expect to get it, and yet that's where the major problem is. Namely, if you have cancer, you're expected that you have significant pain in certain of the cancers and that you're going to require opiates. On the other hand, in non-cancer pain, you expect that there isn't going to be a significant need, and if there is, then it's going to be short-termed. One of the studies that came out just recently from JAMA in January was that there's a increased mortality in patients taking long-acting opiates for non-cancer pain. This is just a series of things that we see all the time, and the real problem is that we're looking at patients who in general don't have a need for opiates, don't have a need for long-acting opiates, and then there's a concern that they have increased mortality. So this adds to the already increasing body of literature that is coming out that says that if you give the drug for the right indication, you get a good benefit. If you give the drug for the wrong indication, you get the wrong benefit. A follow-up on that is that opiates have no benefit for people with chronic low back pain. This is well known in workers' comp, it's well known in group health type of medicine, and that is that the benefits are minimal. We really know that most people who have low back pain are going to have a significant diminution of symptoms and problems over a period of a couple of weeks, and that will happen whether they take drugs or whether they don't. The problem is they take opiates and they have a minimal benefit, and yet they're taking drugs because presumably that's going to diminish the pain. We're dealing with a study that came out of the CDC, and the CDC evaluated and identified from all the studies that they were looking at that they're not terribly effective. On another part of this is that there are alternative ways of dealing with pain that don't require drugs. And while drugs are a convenient crutch for us for everything, there are things that don't require drugs, or that drugs, if you were doing them along with drug therapy, that there's a significant benefit so that you can lower the dose, you can also lower the duration of therapy. There's a new study out of, in this particular case, the Annals of Internal Medicine, and it had to do with Tai Chi being as effective as physical therapy for knee osteoarthritis. Osteoarthritis is a very common, the most common form of arthritis, and it's important to realize that when a person has a diagnosis, clearly there has to be a severity adjustment for how severe is the disease. But in most cases where it's a very mild disease or even moderate disease, then we don't just have to reach for drugs. We have to take a look at other therapies. And clearly issues like Tai Chi and physical therapy are important. The recent article in Annals that came out in May indicated that Tai Chi is as effective as physical therapy. So there's a way of doing this in an ongoing way to deal with that. Now, the other thing I want to deal with pain, but I want to deal with it in a different way, and that has to deal with rheumatoid arthritis in a head-to-head study where Rituximav was compared to other TNF inhibitors like Enbrel, like Humira, etc. and it was indicated that it was, in this case, as effective as all the other ones. That's fine, and there isn't an argument with regard to Rituximav. The real argument, however, is that when one sees a study like this, we want to take a look at methodology, because methodology can be important. And in this regard, this head-to-head study had methodology problems, meaning that there was concurrent therapy with another drug, methotrexate, which is part of the series of drugs that you take and would be taken before one of these drugs like Rituximab or Enbrel or Humira, etc. And what you see is they remove the methotrexate. So in fact, the therapy wasn't the same as you expect for treatment for rheumatoid arthritis. So saying that one drug is equal is another thing. The bottom line message in this is it's important that we see that there's a study, but it's also important that we take a quick review and see, was the study population the same as the placebo or the control population, to make sure that we're receiving the same standard therapy and that we haven't seen some benefit because we've changed therapy. Those are a couple of issues that have come out. The other issue has to deal with a completely different category, has to deal with the newest antibiotics. As you probably know, there's been a huge problem with antibiotics in that many of the antibiotics that we've had for a long time don't work anymore in common therapies. So as people age, they're frequently not susceptible to these antibiotics for therapies and conditions that used to be much easier to treat. Well, there has been a newer study that came out looking at the newest antibiotics, and what's been found is that effectively they're no different than every other antibiotic. The study came out of Annals in May of this year, identifying the fact that these newest antibiotics don't look any different than the other ones. Now, the real issue and the real problem here is that we need the newer antibiotics when people are more resistant. One, because of antibiotics that are being placed in foods, another because of antibiotics that are being overused by the medical community in order to treat problems that in fact don't necessarily require some of these more broad spectrum antibiotics to deal with. The issue, though, that comes up is that many of these antibiotics have been brought out and compared or brought out in the same methodology that we built the first ones. So in effect, these antibiotics look just the same as the others. And so the caveat here is that newer antibiotics aren't necessarily a big boon when in fact there is no real benefit and change. They frequently come out, and the key when you're looking at a study is a non-inferiority trial, which is very common, and it identifies that this particular drug is no worse than something before. In effect, that's a me too. It doesn't do anything that is a new mechanism. It doesn't do anything that's a new methodology. All it's doing is the same thing as everybody else. I think that from our news standpoint, I would ask you and counsel you, take a look at our RX Info Exchange. It's at propharmaconsultants.com/rxinfox.html. The news is there. It comes up in multiple indications with regard to pharmaceutical companies, with regard to evidence-based medicine, with regard to pharmacy, and biotechnology and the new specialty meds. I think you'll find it of interest, as well as, of course, pharmacy benefit news that comes out every other week. They're free. Everybody can look at them and address them. We look forward to talking to everybody. I hope you have a wonderful day and an outstanding week. And remember that for in future broadcasts, when you're on the RX InfoX Exchange, there's a bar right at the top that says click on it in order to get to our broadcast notification, and you can watch this at any time. Remember, we're going to do this every Wednesday at about 12 o'clock Pacific Standard Time, and we look forward to talking to you. Have an outstanding week and a great holiday.